Just want to give a simple introduction. Erickson once said, life doesn't make any sense without interdependence. We need each other, and the sooner we learn that, the better for all of us. As practicing infertility specialists, we now know how integral it is to have an endoscopy in our practice. To just tell that in a different way and to welcome others, I'm now inviting Dr. Mansi Jain, who is a consultant reproductive medicine endoscopic surgeon at KJ IVF and Laparoscopy Center, Delhi, Indrapuram, and Faridabad. She is a co-convener SIG Endoscopy IFS 2022 and 26, executive member IFS, and a national coordinator of SIG IFS. She has done a fellowship in reproductive medicine from Thomas Fertility Center, Singapore, and fellowship in minimal invasive surgery from Max Hospital, Saket. She has written many chapters, delivered numerous lectures and video presentations. I will hand over to you, Dr. Mansi.
Thank you, Dr. Sopnika, for such a kind introduction. A very good evening to everyone. On behalf of SIG Endoscopy, I feel privileged to welcome you all for our joint webinar today with the Karnataka chapter of IFS. Before we proceed with the academic session, I would like to give you a quick intro about my SIG. So, Special Interest Group Endoscopy is a specialized group of IFS which deals only with endoscopy in the infertile population. We have a very hardworking and a dynamic team, which is mentored by Dr. Professor Kuldeep Jain, and Dr. Parul Kotadwala is the convener, and the co-conveners are Dr. Deshdeepak Sir and myself. So it is our aim to promote the correct and ethical practice of endoscopy in the infertile population. And it is a constant endeavor to associate with all chapters of IFS and the local OBS Gynae Society, and not only nationwide, but also internationally. I also feel very proud to tell you all, to share with all of you, that this year we were also awarded the best SIG at the National Fourth Division. With this, I would like to extend a personal invitation to all of you for our next upcoming webinar on the 10th of May, which is a collaboration with the IFS UK chapter. So it's going to be an exciting session. We have the best of the speakers, best orators who are stalwarts in the field of infertility and endoscopy, and the discussion is going to be amazing. So all of you are welcome to join. I'm sure all of us are going to benefit from this. And without wasting further time, I would like to hand over the session to Dr. Sopnika to proceed.
Thank you, Dr. Mansi, for that wonderful introduction. Now I would like to invite our chairperson for today, Dr. Chaitra Nair, who is our beloved teacher. She is the secretary of Indian Fertility Society, Karnataka chapter, and founder of Kalpa Clinic and myivfdoctor.com. She is a visiting consultant at many infertility hospitals in Bangalore and visiting faculty at Medline Academics, National Board and RGHS recognized teacher for reproductive medicine, member and subject expert at Institutional Ethics Committee IIRRH. And she's invited faculty for many national conferences, authorized multiple textbooks and chapters. Welcome, Yuma.
Thank you, Sopnika, for the kind introduction.
Our next chairperson, Dr. Mangala Devi, she's yet to join. She is the director of Smile Baby IVF Center and then the president-elect BSOG and the treasurer of IFS Karnataka chapter, founder EC member of Karnataka chapter. She is a speaker, chairperson, and judge in many national and also the local state conferences. I'll be waiting for you, ma'am. So, without wasting any more time, let's move on to our first topic, acquiring the basic skills in MIS, minimal invasive surgery. For any subject to be understood in depth and practiced with skill, the prime necessity is learning its basics. For that, it is very much important to learn what is there in the basics. We have Dr. Prasan Vis, who has done his undergraduation and post-graduation from JIPMER and a reproductive medicine fellowship from CMC Vellore. He is now heading the reproductive medicine and surgery at St. Stephen's Hospital, Delhi. He has special interest in male infertility and endoscopic repairs. He is teaching postgraduates and many fellows in reproductive medicine. I welcome you, sir. Over to you.
Hi, good evening, everybody, and welcome to these deliberations on MIS. I hope I'm well audible, everybody. Is this good?
Yes, sir.
Yes, doctor.
Yes, sir, you are.
Yeah, hi. Thank you so much. Thank you so much for the confirmation. I'm sorry. And great to see all of you. And Mansi, thank you for inviting me over for this SIG and looking at the enthusiasm one of my students has. I remember taking Mansi's exam a long time back. So the kind of growth she has, it's exciting to see that all these postgraduates who are trying to get into infertility and endoscopy and also in other specialties, they are doing so well. So yes, good to see you, Mansi, and good to see Dr. Sobarnika. My regards to the chairpersons here. So we are going to be discussing about the outright basic skill acquiring about MIS. Now, this session is basically for the postgraduates, I feel, or those who are doctors and want to become they want to participate in laparoscopic work. They also not so they can, but a basic requirement is to do some training in obs and gynae, and that would be a DGO at least, or an MD or a DNB. Now this lecture is basically primed for them so that how they can develop the skills. So I'll try and brief this out into the basic segments of what we have to do and how much we have to learn, because doing an MIS course itself, it's a 3 years course. If you all, I'm sure you all know very well. It's FNB for 3 years now. So let's see how much we can understand in this brief presentation. So greetings from St. Stephen's Hospital, Delhi. And we are going to be discussing about MIS now. So when we talk about minimal invasive surgery, yes, it does have the basic elements of interest for us gynecologists, which is of course laparoscopy. But yes, it is also about arthroscopy, about gastroscopy, thoracoscopy, etc. Of course, it all started with laparoscopy long back. The first laparoscopies were indeed the gynecologists. But yes, eventually laparoscopy, endoscopy has found its way in almost all specialties now. And of course, the next step of doing all these endoscopies is to specialize into robotic surgeries. So when we talk about MIS, it's basically the small incisions to achieve the same surgical goals, which all of us know are done in routine surgery, as all surgeons here will understand that. And we use miniature imaging systems to achieve these goals. And the first goal itself, we know the first achievement is lesser trauma to the patient and faster recovery for the patient. So yes, smaller wounds, lesser complications. With MIS, we all know that there are lesser post-op infections, lesser pain, lesser bleeding. Hernia instances are much lesser. Of course, there are a lot of umbilical hernias. I'm sure some of you have also seen them. But yes, the patient has a much faster recovery after MIS, after laparoscopic work, and need to say the cosmetic advantage. So yes, it does make sense to give a few incisions on the abdomen, which are around 1 centimeters. But yes, don't exceed more than 4 or maximum 5 if you're taking out a big tumor. Because if you're making 6, 7 major small incisions on the abdomen, I would rather say go ahead and make a 7 centimeter, 8 centimeter incision suprapubic and take out the tumor. So if you're putting just too many ports, then you're not doing minimal invasive surgery, you're invading the abdomen. So let's not invade the abdomen with too many incisions. Yes, the cosmetic advantage is that if you're limiting yourself to a 3-port or a 4-port surgery, so we all know that work will give surgical time and less exposure to the anesthetic agents. And that's why most of these procedures can be done daycare, or a lot of these patients, even if the big surgeries which we do, they can go back home the next day itself. Yes, hemostasis can be a problem, which we all know very well. The gas pressures, that they help us to reduce the bleeding. But yes, if a patient starts bleeding, then some of us have lost our sleep over that. So hemostasis can be a problem in endoscopic work. So yes, what I feel is my idea, and of course, a lot of my friends who would feel, those who are my contemporaries who started working with me, that when we are acquiring the skills for minimal invasive surgery and laparoscopy for us gynecologists, I would want everyone here to understand the importance of working very hard in the post-graduation level itself. So when you're a postgraduate, please do a lot of cesareans. Assist in a lot of major surgeries which your consultants are doing. Please do not shy away from standing next to a surgeon. Please, that's your best training. See, every surgeon, you might be the PG of Unit 2, and there might be a very good surgeon in Unit 3 or Unit 4. And take the opportunity to go and assist that surgeon. Please learn open surgery. That's the first and the bottom line statement of this presentation. If you're not doing enough surgery, then forget about even thinking of doing laparoscopy. I'm very vehement about that training part of your life. So please assist as much as you can. And I'm very surprised that when students come to join gynecology, the first thing they try to come and meet the consultants in the department before they put in the papers, and first thing they'll ask, how many hysterectomies I can do when I'm doing my PG. You must say how many deliveries are done in this hospital. You must find out how many complicated cases are referred to this hospital. So if there are more complicated and more deliveries, it eventually turns out that this hospital is going to have many more surgeries like laparoscopic work, and there'll be much more options. If this is a busy hospital, find out if the hospital is busy, you acquire your skills. So do a very dedicated post graduation, and after that, it's a must that once you've learned the basics of assisting, I'm repeatedly saying, do a few cesareans, and if you can do a lot of episiotomies, learn suturing on episiotomies. After the first 50 episiotomies, the next few episiotomies, you can start doing, apart from the mattress sutures, you can start putting the subcuticular sutures on the episiotomy. You can try and do the single knot episiotomy. Get your hands into the surgery when you're doing episiotomies. And after that, get into assisting a few hysterectomies. If you can get a few hysterectomies wherever you're doing your post-graduation, that's an advantage. Please, making you people do a hysterectomy in your post-graduation, it's not a compulsion by any medical college. It is a added advantage that if the hospital has a lot of hysterectomies, and if you can do a few hysterectomies yourself, great. But many colleges are not medical colleges and they're private places. So learn by watching. We always say that. But yes, the next point of this session is to understand the importance of SR-ship, senior residency or registrarship, or whatever you call it, or some places call it a associate consult post. If you are not doing these 3 years, then your hands have not run into the blood. You have not run into the system yet. Please, whoever is watching this, please understand, if you're not doing SR-ship, then jumping into any super specialization which is associated with gynecology, it's a half-baked job. A lot of you want to immediately after your 3 years of your MS, you want to get into a super specialization course, and you have not yet done even 20 odd hysterectomies. You have not done enough open ectopic pregnancies. You have not done many, laparotomy and lavages. You have not assisted bowel repairs when, so many times your surgeons can do the repairs. Your consultants of gynecology, they do wonderful repairs sometimes of bowel injuries and bladder injuries. So you've not learned those repairs, if you've not had many discussions about how that patient is going to do after this repair and what is the post-op time for recovery and how many nights you're frustrated seeing that the patient's bowel sounds have not come and the patient after taking out the catheter is able to void herself properly because you had assisted in a bladder repair with surgery, whatever happened when a patient had a bladder injury. So that is what happens in SRship. You guys, after your training of your PG in your SRship, you learn to manage complications and you become a much confident individual. So I would say at least 15 hysterectomies, open or assisting, open or laparoscopy, if you can get your hands on laparoscopy during SRship. At least 15 hysterectomies you should do. I mean to say 15 hysterectomies will come to you only if you've done at least 200 odd cesarean sections and you've done a lot of ectopic pregnancies, you've done a lot of DNCs, you know what is a perforation uterus, and you know that in the middle of the night also you can put in a scope and suture that perforation if there's a laparoscopic surgeon available in your hospital. And after your SRship, that is the time in your graph, the next time when you become a junior consultant, between this time, post SRship or maybe the last 6 months of SRship and the beginning time of your junior residence, junior consultant's job, it is this time when you should be doing your MIS training. This is the time when you'll understand the importance of MIS training. Look, after your PG, if you go and stand with somebody as senior as PG Paul or Dr. Hafiz, and these guys are doing this work in their even in their sleep now. I mean, these guys have made hundreds of graduates become super specialists in laparoscopic surgery. So if you go and stand with that gentleman, he's going to tell you to hold this organ, hold this clamp and cut at this side, and then go and put the next clamp and cut at that side. And you feel that you have assisted in 15 hysterectomies with senior people. You have gone and done so many at this training center for 2 months or 6 months. After post-graduation, that training will give you happiness. It's not going to give you the confidence. Moment you come down to your own hospital, which your mummy or papa is running, and you are now part of that big hospital, and you're suddenly, you're X this big institute and X this big training institute for laparoscopy, and now you're starting to operate. When you're going to operate alone for the first time, forget doing a TLH and forget doing an LVH, doing the first ectopic, and when the tube starts bleeding, when the base when the mesosalpine starts bleeding, and the first spurter which comes onto your lens, that is going to make you have abdominal cramps. Believe you me, guys. So please, till you do your SRship, don't get, see, surgery is a long haul. Whenever you do general surgery or you do gynecology, you're ready for the long haul. You're not a person who is here just to do that degree and get into laparoscopy. You are getting ready for the long haul. If you're doing MD medicine, fine. After 3 years of your MD, you can join any big hospital and you can be called a consultant of cardiology, because the skill is in all in the brains. You don't have to learn to operate. But when you have to learn to operate, you have to give yourself time. It's a very, very patient skill, surgery. So once you do that 3 years SRship and then get into training with MIS and get into need super specialty, let's say if it is laparoscopic surgery or if it is into oncosurgery or even if it is IVF, then is the time when you understand surgery well, because you've done so many open procedures, you've assisted in so many laparoscopies. So that's the time when I want you to do your MIS training. Last 6 months of your SRship and also the first 6 months of your junior consultancy. You can join a course, you can operate because you're a senior doctor yourself. There are other senior people who are doing the procedure. Go and do this at a place where you are working as a registrar. Always the learning level, the learning level is not as a consultant. The learning level is always at the level of a registrar or as a consultant. So even if you're a consultant in, let's say, in a big hospital, please go and join as a registrar in one of these hospitals where they are allowing you to operate and where they are doing laparoscopic work and they're allowing you to learn with them. So that's the best kind of training. Yes, there are courses for 2 weeks to 6 months. Some places are giving courses for 1 year. Those places also you can go and join. There are many institutes across the country, and some of them are excellent for getting this training done. But that training is going to rub on you only if you've done this. So yes, next thing after getting into the training, As a junior consultant, I would want you to start doing your diagnostic laparoscopies and your ectopic pregnancies at that time, and some operative work, like I said, ectopics and small ovarian cysts, para-ovarian cysts. Try to get into those. And yes, finally, when you're 8 to 10 years, yes, when you're 8 to 10 years in your life as a gynecologist, and you've gone through all of this training, that's the time when you will start doing your LAVHs and TLHs. And God bless you if you're doing lap myomectomies, endoscopic suturing, and you're doing the repairs. An excellent surgeon is going to give a talk about repairs of Mullerian defects following this talk. So when you reach that 8 to 10 years of a grind, and that's the time when you've done enough open work, you've done some laparoscopic work, and now you're individually doing. So you know one thing at this moment, that you can manage complications. When you can manage complications alone, yes, there's always be a requirement of a general surgeon behind you, because we may injure the bowel sometimes or the bladder sometimes. And most of these things we can repair laparoscopically. But yes, you always want a certificate from the surgeon or him to come and assist when something goes wrong. So this is the way I want you to develop your skills. Then yes, of course, we must learn about the basics about the equipment. Any surgeon, any laparoscopic surgeon has to understand this trolley very well. If you know, I mean, all the instruments, how they work, that is where you start learning the management of an operation theater. Look, you can assist in multiple hospitals with multiple doctors who are doing very good laparoscopic work. But if you don't understand the instrumentation, you'll never be a confident individual laparoscopic surgeon. So learn instrumentation properly. That's my repeated request to all you youngsters. So please remember, learn about the camera control unit. You should have a good LCD LED monitor, the light source, and a recording equipment. Let's see a little bit about these things. The camera type which we all use these days, of course, I wish my hospital gets this very fast, but yes, we have a HD camera. But now what is in is the 4K near immunofluorescence infrared imaging. With this infrared imaging in a background of ICG is what is in now. And this is 4K resolution. Now 4K is basically 4 times the normal, the normal resolution of high density video which you see, the HD videos which you see on your regular laparoscope, regular LCD screens which you have in your OTs, or even the television you have at home, and even on YouTube when you see it on your laptops. So that is generally around 1080 pixels. So this 4K is 4 times of that. So 4000 pixels, that kind of clarity. So these cameras are now 4K, and this is now the next best thing. I mean, I'm telling you the next best things, because yes, all hospitals, all government hospitals and missionary hospitals, if they have them, then life would be wonderful. So we have the HD cameras still, and we are doing good job with that. But yes, 4K is the next big thing, and I'm sure a lot of you are working with them. And then when you have this near infrared fluorescence imaging with the IC background, the wavelength of this is around 650 to 950 nanometers. And it is good for in vivo fluorescence imaging because it's good tissue penetration and it has low autofluorescence from adjacent tissues. So what is the meaning of that? What is the advantage of this? That when we're using NIR, then there is enhanced visualization of the anatomical structures. There is improved surgical precision and decision making while you're operating. And of course, there is reduced operating time. When you see everything clearly, obviously the operating time will reduce. So these are the new gizmos which we have now. The light source, yes, it has come through a lot of evolution. And the traditional, when we were doing a post-graduation in JIPMA, I remember we had the traditional halogen lamp light source, and it was good enough. It was a yellow light, but yes, the white balancing, you should take care of that. And then the xenon light source came up, and those were much brighter, longer life. And then the metal halide light source. But now the best way to have a light source for your laparoscopic work is to have the LED light source with a fiber optic cable. So when you're using this LED light, these are cold white lights. The best thing about them is that they don't heat up. And there were times when yes, all of us have done this mistake of putting this light cable on when we're using the halogen light sources, and those tubings, they will be lying on the drape, and this light, if it is in contact with the skin. It can cause a skin burn. So that kind of temperature used to come in these cables. Of course, skin burns have not happened much, but a lot of times the drapes have started singeing because of these light sources. So please, now we all have to get into the LED light sources. These are the white light sources. These are cold light, and there's no damage to the fiber optic cables because of this light. And the best thing about them is that they have a very long life. I mean, basically, you don't have to change the bulb. That kind of advantage you have. So it saves, the cost, because for the number of years it is going to be useful. So it is saving up to 90% of your cost when you're using the previous light sources. Like, let's say if you are having 3 OT days in a week, on average, some of you are doing mostly only laparoscopic work, some of you are doing twice a week. So on average, if you have 3 operating days when you're doing laparoscopic work for, let's say, 10 hours daily, so you have 12 days in a month, and that's something like, in a year you have, in 12 months you have something like 144 days and 1440 hours of the light source used, and with 30,000 hours. So if you divide, a simple calculation will tell you that these light sources can be used even up to 18 to 20 years if you don't actually jump on them and break them. So these light sources are actually the next best thing, very cost effective and very comfortable to use because they don't give any heat while you're doing these procedures. And invest in a good monitor, a 31-inch monitor. Some people are happy with a smaller one. Gone are the days when you had those medical monitors, the Sony wala operator, of the monitor which we used to have. Now, of course, everybody has LCD and LED screens. So this 31-inch monitor should be that medical grade monitor, which are even better resolution than the television which you're seeing. Yes, a lot of places I see that when you're operating, you have one screen for yourself and your assistant is seeing on a screen behind. But the juniors are actually watching on a television gifted by some company. So that television actually sometimes is such a nice television that, we are also looking at the television which is there in the OT, and that is giving us a still better picture. Because nowadays we have OLED technology and we have triluminous technology in Sony. So yes, all of these, the medical grade monitors are supposed to be even better. So try to get a good display where there is 3D and 4K resolution or 3D and full HD resolution at least. So invest in a good monitor and then a recording system. Now, that is documentation of your work. All of you are going to be very busy surgeons, and if you're not recording your work, you know, at least start recording. There'll be some evenings where you'll be totally jobless, then start learning to at least edit your work. So when you have a good recording and you have time to edit, invest in a good software which is going to allow you recording from the camera head which you have in your hand. Most of these, like I have a Smith and Nephew camera system, we have on hand recording buttons, and you should have the capability to record a video or take an image while you're doing these procedures. So understand the camera unit very well, understand the importance of recording and telecasting. So many times you'll be operating while this is being unicast being to the conference hall of your hospital. You're operating in the OT and it's going to the conference hall, and there's a conference going on and live sessions will be going on. So once you learn all of this, it's very exciting. So please learn image recording, data archiving, signal management, and streaming. So yes, you should have a capturing in 4K Ultra HD or Full HD, and then you should have an internal storage in the monitor of at least 4 terabytes, and recording should be possible straight away onto USB drives. So USB drives, very convenient, just plug in, do your surgery, record it, plug out, go home and watch it and edit it. As simple it has become. For the last 15 years, it has become like that. I mean, it was there, all of this was there even earlier. But then for the last 10, 15 years, it has become so common that all of us, we have our own recordings and we can edit them ourselves and we can go for a presentation like this one, which we are doing, a hysteroscopic myomectomy here with a Versa point. So yes, when we have these recording systems, they should be having 2-channel simultaneous recording for still images and videos. And this should have storage of this on file servers. And then you should be able to do a unicast streaming in full HD, like on a local area network when you have to stream it to the conference hall, like I was telling you about. Right. So, excuse me. So, what are the laparoscopic instruments which you have to invest in? So, yes, we have the traditional laparoscopic system, which used to have the Hobson's, the traditional telescopic lens, which had multiple rod lenses in them. Now, this Hopkins lens system is still very much in play, but what happens that they have a life, they have a shelf life. All instruments do have a shelf life, and they often used to have a more frequent breakdown. So yes, nowadays we have a digital laparoscope, which basically is a chip on tip kind of a technology. It is just that on the laparoscope itself, on the tip of the laparoscope, you have a digital camera, and the camera is taking, it is showing you live, and that image is registered by the chip which is there in the lens, and that is then beamed onto your monitor. So rather than having a lens system, a complicated lens system, the laparoscopes, the endoscopes now have this digital chip, the chip on tip technology. So these two laparoscopes you can invest, and all of us know that they are 30-degree 10 mm main lens and a 5 mm 30-degree side ports. This is a very necessary basic investment. Yes, some of us are very happy using the 5 mm just when we're doing the diagnostics. But remember, the 5 mm, even they are the 3 mm scopes when they are pediatric cases, but they don't have a very good depth while you're doing a diagnostic procedure. Definitely not very good for operative procedure. But yes, a lot of us, 5 mm also, we have done surgeries with 5 mm, and most of us would say that yes, if you want to actually give much smaller incisions on the umbilicus, the infraumbilical incision, then you can go ahead with the 5 mm 30-degree also. And most of these telescopes nowadays, they're all fog free, and they have focus free functionality, that you don't have to keep thinking about doing a focus every time you beam in and beam out. Yes, this has this basic advantage is there now ever since 15, 20 years, that most of these endoscopes which we're using are focus free, eliminating the use of manual focusing. And then the CO2 insufflating unit, you should understand that now we have these very fast insufflators. Of course, you should always start with, when you're putting in your various needles, some of us do go gasless into the abdomen, but then if you're using CO2 and you're going in with the varus, then please start with 1 liter a minute, go slow. And if you feel the pressures are just around 5 to 8 of the abdomen when you put in the varus, and it's not getting too much, and you're not into some organ, and not into, God forbid, into a vessel, then, and when you see the air is flowing well and the abdomen pressure is lesser than around like I said, 5 to 8 millimeters of mercury, that is what is giving you the assurance that you're at the right place. It's always good to go very basic and go in a way that you can have lesser complications if you follow the outright basics. I don't want you guys to suddenly follow the chief surgeon of your unit, and who actually goes it with 3 liters flow immediately because he's confident where he's gone. But if you're doing your first few laparoscopies, then please go start with 1 liter per minute, and then you can increase up to 2 liters or 3 liters. You can also go up to 45 liters in sufflators, which is 45 liters of carbon dioxide, which can go into 1 minute. So the pressure is obviously not up to 30 like given in this figure here. It can keep the pressure to 30, but yes, operating pressures, all of you know, should never be kept more than 14 or 15 in your manometers. So please take care of that. Now we also have these heatable insufflation tubes, so that the carbon dioxide, when it is going into the abdomen, is not giving a cold shock. It is at the body temperature, right? Then you must understand about the scopes. You must understand that disposables are always better, and they have a very comfortable tip, which is it is multi-purpose tip. It is going to avoid injuries when you're putting your trocars, and these trocars will also have views, so that sometimes when you feel the adhesions, you can put your scope into the head of these trocars, and you can see how you're going into the abdomen. So just in good disposable scope, disposable trocars and cannulas, and of course the surgical instruments. This I wish we do a talk about surgical instruments once you people learn basic skills, and then one of these days we should sit and talk about the instruments which are going to be used, for what kind of instruments you're going to use for surgeries, and what kind of cautery instruments you're going to use, and what are the recent developments. And it's a very exciting life when you become an endoscopic surgeon. There's so many modifications coming every 6 months. So basically, you must understand the use of disposable trocar and cannulas. Yes, there are a lot of doctors who are still very happy with the metal ones, but yes, metal ones having sharp tips, more injuries. So I would say beginners, if you have these, especially the Ethicon EndoView, the trocar and cannulas, these are a very good investment. So learn about the instrument, learn about the trolley, learn about the working of these cameras, learn about how the pressures are monitored, and why there is suddenly, you are in the middle of the surgery and there is sudden alarm from your hysteroflator or from your endoflator. There is some block somewhere. If your tubing is blocked, or there is some problem with the patient's positioning, or the tube has basically got kinked, or your assistant is actually standing on the tube and you've not placed the tube properly, you must understand where the problem is, because troubleshooting is what a good laparoscopic surgeon should be having the knowledge of. You must know what is going wrong. There's no point there's no point just getting into laparoscopy and not knowing how to manage complications. Because see, if you don't know what's happening, why the vision is very poor, and why the focus is not good, and why you've forgotten to do the white balance and your picture is all blue, if you're having that kind of a picture, then there's no point shouting at the nurse or the floor nurse or the technicians who are around you. I mean, if you've not done your basic training well, you'll actually waste a lot of time getting uncomfortable and frustrated while doing a surgery. You'll do much longer the surgery, and you'll end up with many more complications while you're doing all of this. So please understand the instruments well. I remember before I started doing laparoscopic work, the only training I took during my SRship, yes, believe you me, I was doing my labor room postings. We have 1 month labor room postings, 7 days daytime, 7 days nighttime, alternating shifts. And I used to do nights in my hospital where I'm working right now. And in the post night off in the mornings, I used to go and work in the Carl Stores outlet in Okla in Delhi. And I used to just basically learn the instruments. For 2 weeks, I've done that just to understand the instrumentation. So learn how you'll understand to manage the complications, but before that, learn how to manage the instruments. Something goes wrong with the instruments, you should be the first one who will be taking care of them. All right. And before you call the biomedical team, you should know what you're calling him for. All right. And earth your cauteries well. Don't cause unnecessary burns on the patient, and learn to adjust the OT table. You might become a very good laparoscopic surgeon who is getting in and out of multi-OTs in the city. And if you don't know how the OT table works and you're not in a comfortable position while operating, you'll end up with more complications. I'm telling you, positioning the patient also is an important part. We'll be coming to that. Right? So positioning the patient. If you're having a laparoscopic work to do, then the traditional and most surgeons who find themselves comfortable is the low lithotomy position, the one which I've highlighted here. Of course, lithotomy also can be a standard lithotomy or a high lithotomy, but please go for the low lithotomy position, where basically you have the hip flexion around 60 degrees. You can make it around 90 degrees also, but around 60 degrees enough. Knee flexion of 90 degrees to 120 degrees, and a mild and an abduction of the hip for 90 degrees, and minimal external rotation. You keep that low lithotomy position. That is what is best. And that mild hip abduction helps you when you want to go down and suture the wall sometimes. So you should have a comfortable space. So before you put the scope, go down and have a look. If you have a good assistant who can tell you that there is comfortable space between the legs for you to sit and put a suture high in the wall, yes, you can be a very good total laparoscopic surgeon, but then you will start with alleviates. And like I said, your number of vaginal hysterectomies you've done as a postgraduate or as a SR is going to help you eventually when you're doing your laparoscopic work. And please learn proper port placements and comfortable port placements, because there are times when you're going to do just a diagnostic scopy, but when you're going to do an operative work, you should be ambidextrous while you're doing laparoscopic work. Please learn to use your left hand. Of course, if you're a left hand person, then of course learn to use your right hand well. So learn both your hands. You should be ambidextrous when you're doing laparoscopic work. I've seen people standing on the left side of the patient and trying to operate with the right hand. It's going to be so tedious and so uncomfortable for the person. Forget the result of the surgery. So if you're not ambidextrous while doing laparoscopic work, let both of your hands work well. So eventually it all goes back to what I said in the beginning. Please invest in basic 3 years of SR-ship. All right. So learn your port placements well. And initially you'll need help in suturing. So let a good port be placed on the contralateral side. So your senior surgeon can help you while you're starting your initial suturing in endosuturing techniques. And later you can keep both the ports on your side and do the suturing ipsilaterally. But yes, ipsilateral suturing is going to take more skill because you're going to be having some scissoring effect. Right? Learn about injuries specific to laparoscopy and should be confident to recognize and manage injuries. Have a backup system with other specialties. I think I hope I'm not stretching my time too much. I think I am. So
5
I
more
think
minutes.
I'll yeah, it's all right. I'm almost done, Dr. Sovarnika. So have a backup system. Be always very good friends with the surgeons. You never know when in the night when you're doing emergency laparoscopy, they're going to be of help to you. So do all of this in a good institutional setup. That's what it is. Operate all of this only in an institutional setup where you have help at hand. All right. All of us cannot be urologists and gastrosurgeons when we are laparoscopic gynecologists. If you have those skills, it's good. And learning to observe. Yeah, learning to observe is what we say is a simple matter of watching well. So observe and learn. Try to learn when you're seeing, like I'm assembling a scope here, I'm making sure my residents understand what we're doing. Try to learn when your seniors are operating. You don't have to always be eager to just get the chance of putting in the scope. That will eventually come in your life. So please observe and learn as much as you can, and then understand that you are eventually going to get there. But before you get the instrument in your hand, how many dummy mock assemblings have you done? How many have you done this when you have the instrument set? There are a lot of instrument sets in all hospitals when the exams are done. How many times have you used those instrument sets to assemble instruments? So yes, try and learn when you're observing, and use the time to do this dummy practice with the instruments. That most of you, I've actually asked my fellows right now who are doing, and they are when they are doing laparoscopic work, I've always asked them, have you done the dummy assembling of the instruments? And they said, yes, always. When we take out the instruments out of the department, we always do the dummy assembling. So that learn, finally, when you're going to do the procedure yourself, you're already one step ahead. All right. Don't just jump into the surgery. All right. So all of this I've told you about the status of things which you have to see about the insufflator and learn troubleshooting. But yes, this last line which I want you to take heed right now: maintain a logbook when you come for a placement to any major hospital. Please make a note of what all you've assisted. Some good places will see how much work you've done standing with the senior doctors. It's not that you've done 10 alleviates and you come into a major hospital. If you assisted 100, then we know that you have gone through the grind. So your assisted surgeries also count. Yes, your working surgeries will always count, but your assisted surgeries count more. All right. So I want you guys, all of you, to get to the level of doing this suturing work. All right. I want you to understand that lap myomectomy, when you do, or you do repairs, like my senior friend who's going to come and speak about Mullerian repairs. So if you're not you're not a good endoscopic surgeon if you've not learned your suturing techniques yet. All right. So I want all of you to reach these levels. So all the best with your preparations for minimal invasive surgery. Invest in a good, hard learned and hard-working registrarship. I have always said that. All right. Thank you so much for your time, everybody.
Thank you, sir, for walking us through the basics. I think you have understood the young minds very well. You have made us understand how to do the skill development. We were all thinking it is only the MIS first, but you have made us understand open surgeries are the stepping stone for the MIS. Thanks for that. I would like to ask Dr. Chaitra to put her remarks on the top.
Yeah,
Thank you.
thank you, Dr. Prasanna. Great talk. Very pragmatic, practical, especially for those of our fellows, young people who look at the Facebook ad, 8 or 10 hysterectomies over the 2 days or 3 days, whatever, and they think, they forget that they are gynecologists and rather obstetricians. We wait for 9 months for a baby to come. We forget the learning curve that is involved in any surgery. And I think
Precisely.
it helps us space that it real we make we realize that it takes that long time to get to where we are or wherever you are. So that's really a great talk. When I saw the topic, I thought it would be the same placement of ports and other things, but this is a very practical and pragmatic talk, especially for our young doctors, who come and ask how many laparoscopic LAVH will we do, and that's a difficult question to answer for us.
I know. You should tell them that you will be assisting, 50 laparoscopic hysterectomies in this year, and that should be enough for you.
No, that is
You'll
what,
get good.
because yeah, not all mistakes can be done by one person over maybe 1 year or 2 years. That is what, as a postgraduate, we were taught, that you go on assisting people and you learn from their mistakes. You don't have to make those mistakes. But yeah, you have just reiterated the same. So it's great listening to you. Great talk. We look forward to your talk on the instruments. That would be great
Thank
again.
you. Thank you so much.
Thank you.
If at all you people have any questions, post it in the chat box so that we can take it at the end. So moving on to the next talk, Rare Mullerian Anomalies by Dr. B. Ramesh. I think Dr. B. Ramesh is one such name which needs no introduction. Ever young and spreading energy all over. The pioneer of gynac and the laparoscopic surgeries in India. He is the medical director and the chief laparoscopic surgeon at Altius Hospital, Bangalore. He is recognized for his significant contributions in clinical and academical circles, nationally and also internationally. He is a chairman of Endoscopic Committee FOSG 2018-2021 and president of BSOG in 2010. He has actively engaged as chairperson, operating faculty, speaker, orator in major gynecological laparoscopic conferences and workshops all over the world. He has performed more than 1 lakh major gynecological laparoscopic surgeries and continues to excel in the same field. Among the first gynecologists in India who have performed an innovative 3D laparoscopic surgery and pioneer of single port surgeries. He has into his awards the legendary award IAGE 2024 and Dronacharya Award ISAR 2024, Karnataka Rajyotsava Award, Aryabhatta National Award 2011, and recently he has also received the Lifetime Achievement Award from BSOG. Congratulations on that, sir. He has authored over 50 articles in the national and international journals, written 4 books, and contributed n number of chapters in the textbooks. Hearing to you is our privilege, sir. And over to you.
Thank you, Sauparnika, for that kind introduction. And I must thank IFS and IFS Karnataka chapter and Dr. Mansi and our president, Dr. Mangla, for giving this opportunity. So I will be talking on Mullerian anomalies today. So I will start sharing. Okay. You keep quiet. I will do. Which one next one? Okay. Then you tell me, I will. Where is the file? Documents. Huh? Hmm. Hmm. Yeah, I think you can see. Sauparnika, you can see the screen now?
Yes, sir, it's visible.
Okay, fine. So thank you very much. So I think Mullerian anomalies are one of the commonest anomalies in the body. They contribute significantly to the bad reproductive outcome and especially the recurrent abortions. And so what do we mean by Mullerian anomalies? So as you know that, in the general population, recurrent abortions, Mullerian anomalies account for 13% and 3.5% in the general population. And embryology, all of you know that the female genital system develops from the two Mullerian ducts fuse at the midline. So if there is any anomaly in absorption of the duct or fusion, so the Mullerian anomalies can result. So these are all the, I think, so it is difficult. I don't have much time to go into the embryology. So all of you know this embryology. And now, how do we suspect the Mullerian anomalies? How do you know that the patient has Mullerian anomalies? So they will have by clinical history and ultrasound and HSG and sonohysterogram and MRI. So these are the methods by which we can detect the Mullerian anomalies. And AFS classification, very convenient to remember the uterine anomalies. The first uh, uh, so, group one is hypoplasia or agenesis. So in this, it can be any agenesis, vaginal, cervical, uterus, or anything. Second group is unicornuate uterus, either communicating or non-communicating, or with horn or without horn. The third group is didelphus uterus. Fourth group is the bicornuate. Fifth is the septate, and sixth is the arcuate. And seventh, we don't see DES drug related because DES is not available. So instead, we see T-shaped uterus. So probably T-shaped uterus will fit here into Asherman, and T-shaped uterus fit into seventh. And now understanding class 1 anomalies, among that MRKH is the commonest presentation, blind vagina and absent uterus. And we have to check for renal problems also. And earlier, the treatment for this is they present at adolescent group with amenorrhea and absent vagina. So the commonest procedure earlier done was Makindo. So it has its own shortcomings and a lot of problems. So that was given up. So now we can see just creating the vesico-rectal space and put the mold there. But there are a lot of disadvantages. So now the popular method is peritoneal pull-through, that is David-House, modified David-House. Though the many people say laparoscopic, they give their own name, but the original surgery was done by David Howe. So the credit has to go to him only, not the laparoscopic surgeons. So now you can see this video here, how we do the vaginoplasty for in MRKH syndrome. You can see the absent uterus and you cut the peritoneum. So it is nothing but neovagina creation in the pouch of Douglas. That's all. So if you understand this principle, I think the surgery becomes easier. And you can see the peritoneum is cut and develop the recto vesical space. Because there is no uterus in the center, you have to be very careful not to injure the rectum and the bladder, and go in proper plane. And now we have the free peritoneum, which can be passed into the vaginal side and stitch it to the vaginal edges, so that now the pouch of Douglas becomes the neovagina. You can see the peritoneum is taken from all the four quadrants and fed into the vaginal side after opening the vault. So the neovagina creation, so that it is the peritoneal pull through is achieved, so that the neovagina is lined by the, so you can see here all the where quadrants are taken out and into the stitch to the vaginal mucosa, so that the pouch of Douglas, this space forms the vagina, and you close the rooftop with the suture, so that, and post-operatively they need dilatation, otherwise it can undergo cicatrization. And now you can go to the next slide, Ma. Yeah, this is okay. So advantages of this peritoneal pull through is the vagina is lined by the peritoneum, and scarring risk is very minimal, and we are not using any grafts or flaps to create the vagina. Unlike, they put ileal graft or sigmoid graft, that is a very barbaric surgery. Just to create the simple vagina, you are cutting the intestine, cutting the sigmoid colon, and I think those things should not be done, because it is dangerous to the patient. Not that cannot do, we can do it, but it is not correct to do. And the next procedure for MRKH is laparoscopic modification of the vachity. So in vachity, it is the traction. The vaginal formation is by the traction. There is a mold which is placed in the vagina, and the traction is applied from the abdominal side, so that gradually you give the traction, and the neo-vagina is formed. So here you can see this, the long needle is put with the thread with the olive, and it is fixed to the abdominal wall, and where every day you go on keeping the traction, so that the vagina is formed by the traction between the recto vesical space. So you can see here, and the needle is going through the between the rectum and the bladder, carrying the ligature or the suture. And this suture is brought out onto the abdominal wall, so that you can give the gradual traction. So you can see here, and this is our own made this plate. In any ordinary workshop, this can be done. And you tie the threads to this plate, and keep on going, giving traction, so that the neovagina is formed by the mechanical traction. So that is the most important thing. You can see this, that this is how the final picture, and you should be very careful about the kinking of the ureter. So following any vaginoplasty, maybe for few months, so the vaginal dilatation has to be done, and sometimes the mother has to be taught to do vaginal dilatation, so that the vagina does not undergo constriction or fibrosis. So the next anomaly is, though rare, but nowadays we see quite common, cervical agenesis. So cervical absent cervix with functioning endometrium and uterus, and there is no connection between the uterus and the vagina, so that there is no outflow tract, so that the patient will have severe pain at the time of the menses, and she is amenorrheic also. And so here we can see how the neovagina is created. Sorry, uterovaginal neo-communication is done. So now this is the uterus, which has no cervix. You can see here the anterior vaginal wall fornix is pushed with a sponge holder, and you separate the bladder and open up the anterior fornix. So that is the anterior fornix, the right, fornix. And you open the uterus right from the fundus to the vagina, through and through, and make a big opening. And now through in this into the cavity, you can see the functioning endometrium there. So we put a huge catheter or abdominal drain and suture onto the uterus and the neovagina formation, so that the uterovaginal communication is established, and so she will start getting the periods, and probably pregnancy, they have to go for IVF. We have not seen any pregnancies after this kind of surgery. Probably they need IVF, because absence of cervix, the natural conception is going to be little difficult. So you can see here the uterus is completely opened up. And if you just open partially, it may not be possible to do the communication. And you need such a big catheter to place it inside. And keeping it for post-operatively for 6 to 8 weeks is the biggest challenge. It will keep coming out. So nowadays we fix up with the non-absorbable suture so that the catheter or the stent remains for more than 6 8 weeks. So, and we give HRT at this time, and beautiful communication is established. And in between, after removing the catheter or the stent, we dilate the communication, neovaginal communication, so that the patient will have proper periods. So I think the fertility outcome is yet to be known, because the literature not much on the pregnancy part of uterovaginal communication. So this is about uterovaginal communication. The next common abnormality is unicornuate uterus. So you can see this either unicornuate uterus is associated with rudimentary horn in 75% of the cases. There can be absent rudimentary horn also. So it has and it may be rudimentary horn, may be communicating or non-communicating. And whenever you see the rudimentary horn, for some other reason, you always try to excise this. So you try to excise the rudimentary horn, otherwise it will go on creating the nuisance like fibroid, hematometra, ectopic, etc. And any fibroid and polyps, all these can develop in the rudimentary horn, and can create problem for the patient. So that is why you remove the rudimentary horn in the first chance to remove it. And another dangerous thing is this rudimentary horn can harbor ectopics, we know. But we had the first case of mole in the horn, in the rudimentary horn, for the first time in the world and in the literature, that there was a mole, vesicular mole in the rudimentary horn, which we diagnosed by ultrasound and beta HCG, which was excised, and the symptoms got settled down. So I'm very happy to say that this is the first case in the world which has been reported. And presence of fibroid in the absence of the uterus. So whenever there is a rudimentary horn, you can see that even in the rudimentary horn, there is no uterus. The fibroids can develop from the rudimentary horn, and these fibroids needs to be removed. So it is a very strange thing that the fibroids can develop here also in the absence of the uterus. And again, that was published in one of the journals. Presence of fibroid in the absence of uterus in MRKH syndrome, which was published. So please go through this. And for the unicornuate uterus, of course, the abortion and the premature delivery and preterm deliveries are very common. So the best treatment for this is lateral wall metroplasty. What we do is do the hysteroscopy and enlarge the uterine cavity. Just give a incision on the lateral wall of the uterus on both the sides, preferably on the side of the ostium where the myometrium is thicker. And you have to be very careful not to perforate the uterus. If you go much deeper, you may perforate the uterus. You have to just do it just to enlarge the cavity and make it sufficient for the pregnancy to happen. And you may put a laparoscopic encerclage at the same time, so that the preterm deliveries are avoided. And all the studies, the reproductive outcome of this lateral metroplasty says that the pregnancy outcome improves dramatically with unicornuate uterus presenting with infertility and miscarriage. So don't wait for the unicornuate uterus patients to abort and abort multiple abortions and miscarriages. So go ahead and do the lateral metroplasty and lap encerclage, so that you make sure that the pregnancy continues and they will have viable pregnancy. So now the next is the duplication or the of the Mullerian anomalies or the failure of the fusion. So both conditions, didelphic and bicornuate uterus. How do we differentiate between a bicornuate uterus and didelphus uterus? Didelphus uterus, there is a rectovesical septum. You can see here, they are completely separated. The two uteruses are completely separated. Whereas in bicornuate uterus, there is no septum here which is separating. And the two horns are widely separated, but they are connected. In didelphus uterus, they are not interconnected, whereas in bicornuate uterus, you can see both the horns are connected and there is no septum. So that is how the differentiation is made. And reproductive outcome, recurrent pregnancy loss is the most commonest complaint. And repeated preterm deliveries, growth retardation, and malpositions are common. The pregnancy outcome of the patients with untreated bicornuate uterus and didelphus uterus is up to 62% of the patients will have childbirth. So another, say 30% of the patients need some sort of intervention because, of course, the pregnancy outcome improves with successive preterm labor, preterm births, but you cannot, how many births you can wait for the patient to have bad obstetric outcomes and preterm deliveries. We have to intervene at some stage. So you can see the comparison of reproductive outcome of didelphus and bicornuate. Because didelphus is a well-developed horn, both the uteruses, the reproductive outcomes are much better. So here you can see up to 35% abortion in both. They can have a spontaneous abortion rate up to 35% and premature birth up from 15 to 25%, and fetal survival rate is from 65 to 75%. So the rest 25% of the patient need intervention. So like there is a lot of resistance from the conventional obstetrician that most of them will deliver normally, or most of the pregnancies go up to term. Why are you intervening or do the unification surgery? But the question is not in the 75% group. The intervention is needed in 25% of the patients where the obstetric outcomes are bad, either in the in the likes of abortion, premature, and etc. And reproductive outcomes, generally uterine anomalies present difficulty in, and that is the even in IVF. So this is how we diagnose by, all of you know that diagnosis is by 3D ultrasound, MRI, or even the simple, but the gold standard for diagnosis of Mullerian anomalies is hysterolaparoscopy. So because, like many times we come with MRI report saying that it is a septate uterus, it will be a bicornuate uterus. Sometimes they will say it is a unicornuate, it will be different. So the final Supreme Court is hysterolaparoscopy. So after ultrasound and MRI, you cannot definitely say what is what. But anyway, the patient needs hysterolaparoscopy for the treatment also. You confirm the diagnosis first and go for the treatment next. And now in cases of bicornuate or didelphus uterus, the big debate is whether the unification is required or not. So you can see here recurrent abortions. These are all the causes of this thing. So anatomical causes contribute quite significantly. Of course, if the patient has recurrent miscarriage in the first trimester or early pregnancy, the unification is not indicated. Only if they have later on abortions and preterm deliveries, the metroplasty is indicated. And live births after metroplasty, after unification, is almost 75% for the first pregnancy and 85% for the second pregnancy. So as you know, as the number of pregnancies increase, the outcomes will be better. And also the chances of live born child increases with each pregnancy because of better vascularization and better uterine conditioning. And metroplasty, I think Strassman metroplasty is still the gold standard. And now we have just copied into endoscopic method, but still the credit should go to Strassman, who has devised the unification or this thing. So you can see here how the unification is done in the next. So this is and also you must do hysteroscopy to confirm the diagnosis. And this is the didelphus uterus. And so by case of, this is a video
This is
of
a case of laparoscopic unification of bicornuate uterus.
so you can see this is
the
the
panoramic
bicornuate
view of
uterus.
bicornuate uterus. Two different horns.
Can you hear
And
the
bilateral
voice?
tubes and ovaries are
Yes,
Hello,
normal on either
Saparnika?
side.
Yes, sir.
Okay.
It belongs to the U3 of the Escherichia classification. We start with the injection of diluted vasopressin to each horn to reduce the bleeding during the surgery. The vasopressin of 20 units is diluted in 200 ml NS. Initially, the dissection is at the utrovesical fold. The bladder is dissected down from the lower segment of the either horns of the uterus. The indications are recurrent abortions, any pregnancy complications like preterm delivery, ectopic pregnancy, prior to IVF and endometriosis for unification. Now the dissection is started on the left horn using a cold scissor from the superomedial to the inferomedial through the whole thickness of the myometrium till the ipsilateral uterine dilator is seen. The dissection is continued. Yeah, now we see the uterine dilator and the incision is continued infromedially till the point it meets the opposite uterine horn. The similar incision is now started on the right uterine horn, middle to inferomedial, the whole length, then superomedially till the ipsilateral uterine dilator is seen. The incision is extended till the dilators in both the horns are seen.
Now the suturing
Now
is done with the barb
done with the
suture.
continuous barb suture
Start first from the posterior wall because
in two layers.
Yeah.
And the suturing is started initially from the posterior angle. The suture is taken from outside in, inside out, including the serosa myometrium, excluding the endometrium. It is in a continuous fashion. So posterior to fundus and then anteriorly. The differentiation of bicornuate uterus on the HSG is separate uterine cavities with the inter or cornual angle of more than 105 degree. On 3D ultrasound, analysis of the fundal contour and the endometrial stripe in the each cavity. On MRI, we see a deep more than 1 centimeter fundal cleft with an intercornual distance of more than 4 centimeter. And in hysteroscopy, you can identify 2 separate uterine cavity where you see similar to a septate uterus. So confirmation is by the laparoscopy. Now the suturing is done posteriorly. Now coming to the level of the fundus. With the unification of a biconate uterus, basically the cavity is made into a single cavity and it is enlarged. So the capacity of the uterine cavity is increased compared to its previous size. We usually give 3 months of cyclical HRT, followed by a recheck hysteroscopy after 3 months to check for the cavity and for any adhesions, if at all present with the suturing. So then she can be allowed to undergo her pregnancy treatment. It is good if she undergoes the cerclage, interval cerclage, what we call the same setting with the unification of the biconate uterus. Now here we take another suture, barbed, starting from the anterior angle up to the level of the fundus. So we usually advise an interval cerclage at the same setting of unification of the biconate uterus, or after she gets pregnant, after 3 months, she can undergo a laparoscopic abdominal cerclage. And an active LSCS at the 37 weeks of gestation. Two-layer closure.
So now you can see the beautiful
is better than a
formation of
single
the,
layer.
yeah,
One
so
is to achieve
the
adequate
uterus is reformed and
unification
there is a single
to prevent
uterus
the future
now,
occurrence of the rupture during the
and we
pregnancy.
do recheck
And for the
hysteroscopy
adequate
after 6 months to
This
check
is a
whether
case of
the cavity is reformed or not. And another very rare case of MRKH syndrome with the functional rudimentary horn. So this is one of the rare cases, probably second only in the literature. The first case was reported by Abhinav Chatterjee from Calcutta. So, and this is a MRKH syndrome with absent vagina. So we had to do the unification in the first stage and uterovaginal communication in the second stage. And so it is, like this patient, you can see the functioning endometrium there. So unification is the same technique as what we saw. So, and because of the retrograde flow, the patient has developed endometriosis, and she's around 18-year-old, and the endometriosis is already there, and you can release the round ligament to mobilize to the center. So these are just the rudimentary horns with the functioning endometrium. So we thought how to, normally we excise this and create the new vagina. But in this case, this is only the second case reported in the literature and worldwide, that for both the cases are from India only. The first case is from Calcutta, from Abhinavesh Chatterjee, which was published, and we have also published this case. So first the unification is performed, and all of you know it is done. And in the second case, we had put copper T or the loop inside, and so this is the unification. So we put copper T for the identification of the cavity, and the unification is done. So we give HRT for 3 to 6 cycles and take her for unification. So you can see here, uterovaginal communication in the second sitting of the surgery. So here you can see this. So that is all, endometriosis is cleared. And I don't know whether that video is there or not, uterovaginal communication. So you put interseed in these cases so that the adhesions will be much lesser. And this is connected to the uterovaginal anastomosis by what the method I have already shown you. So, and our statistics, so last 5 years, we have done number of unifications and number of successful pregnancy, but record wise, we have only 7 cases recorded in the records, delivered a term. So 3 full-term pregnancies. But remember, these were all the patients with bicornuate or didelphys uterus with repeated abortions. 5, 6, then only we take up such cases for unification. And so almost one is preterm delivery and another. So 5 out of 7 patients had a successful pregnancy. That itself proves that this is a useful method in 25% of the patients who have bad obstetric history. So I think we should discuss about this topic at the end of the thing, whether it is worthwhile to do the unification or not. And I think septum. So I'm not going to talk about septum, that, because all of you know much about septum. So other the Mullerian, I don't know whether to call this acum as Mullerian anomaly or not. Acum may not be a Mullerian anomaly, but accessory uterine cavity mimicking rudimentary horn with non-communicating rudimentary horn, and the patient will have severe pain. And so you can see here, the diagnostic criteria is the uterine cavity will be normal on hysteroscopy, and you can see almost like a circumscribed swelling, which it attached to the round ligament. It is always attached to the round ligament. So this is the hysteroscopy on the same patient. Now we inject vasopressin and excise the acum with a harmonic clear cut. You can in fact enucleate. It is almost like a endometriotic cyst. And so develop the proper plane. Don't excise too much of endometrium, myometrium. So you can see here the fluid is all coming out. So once you excise this, you suture the uterus so that our pain will get subsided. So this is about the acum, but this doesn't fit into Mullerian anomaly. This is mimicking Mullerian anomaly. So that is why I'm showing this. One has to be aware of this entity while dealing with the Mullerian anomaly. So next is Ovira syndrome. What is Ovira syndrome? Is obstructed hemivagina. So you can see here there are 2 horns here. and there is a septum which is extending to the vagina, and there is obstruction here. So as there is hematometra formation, so this septum, it forms a vaginal septum, almost like a oblique or transverse vaginal septum. So this needs to be excised. So, and also in these cases, the ipsilateral kidney has undergone agenesis. So they will have only one kidney and two horns and one obstructed hemivagina. And what to do for this is incision either vaginoscopically or by vaginal uh, surgery and inside. So here is the same patient where there is obstruction on the left side. You can see the two horns. This is the complete obstruction with causing massive hydrosalpinx and uterus. So right one, that is the right normal uterus, so which is connected. On the left hemi-uterus is not connected to the vagina. So now we incise the septum. You have to be very careful. The best is to do vaginoscopic resection so that under vision. So in open surgery, like vaginal excision of the septum, the visibility is little bit difficult. So that we have to agree. So I think it is better always to do the vaginoscopic with Collins knife, you can incise. And once you drain the hematoma and excise the septum, the patient is cured of her symptoms. And next one is Robert's uterus. What is Robert's uterus is, there is a septum in the uterine cavity. Ovira is septum in the vagina, and Robert's uterus is, there is a septal the regular septum is almost vertical. This is usually oblique, dividing the cavity into unequal compartments. So here you can see that. So now what is the problem to the patient is that hematometra forms here, and this is communicating. And even if pregnancy happens, she is going to abort. So what we do hysteroscopically is go hysteroscopically from here and incise this septum. So uterine septum, so that all the hematometra gets drained, and you just completely the septum will go, and the normal cavity retains, and formation of the cavity will be good at the end of the surgery. So this is the hysteroscopic, where is that hysteroscopic correction? I will show you how to correct the Robert's uterus. So this is how ultrasound diagnosis is done for the Robert's uterus. So that is the obstructing cavity, and other one is the patent cavity. So I don't understand these things much. You can see here the septum is cut completely with the resectoscope so that both the cavities are resected. So it is quite similar to the uterine septum, which is causing recurrent abortion, but this is nothing but Robert's uterus. It is not a conventional septum. So this was also very rare, and we published in long back, around 10 years back, which was published in one of the journals. And of course, so I think that will come to the end of the conclusion. So Mullerian anomalies are common, especially with recurrent pregnancy loss and premature labor and infertility. And combined hysterolaparoscopy is the gold standard. Till you do the hysterolaparoscopy, don't commit to the patient what is the diagnosis, because many times we often misled by the ultrasound and all the investigations. And endoscopic treatment is feasible and safe for most of these anomalies, and we can give wonderful results after unification, metroplasties, and encerclage, etc. And once again, I thank IFS and BSOG for giving me this opportunity. And thank you, Dr. Sauparnika, Mangala, and Dr. Mansi, who is not here on the screen. So thank you very much.
Thank you, sir. Uterine anomalies itself is like a riddle for us. And I think you have solved the riddle in a very beautiful way and also decoded many of the surgeries which are just as fancy words on the textbook. Probably we don't get to see such surgeries at one go. And I would like to ask the chairperson to offer their reflections on the discussion which we had now.
Yeah, thank you, Dr. Ramesh. Very nice talk, because these are very rare anomalies which we as regular fertility specialists just refer to the endoscopy surgeon. So we would not see how it is repaired, and it's very difficult for us to counsel a patient if we see a patient with such a rare anomaly. Now it gives us that additional power, because we have seen your surgeries, and we can actually tell the patients what is the prognosis that they could look for if at all we see such a patient. So great talk. You are the Bhishma Pitamaha of endoscopy as usual. So I think no words can, you know, explain or compliment more. So you are the guru of endoscopy. I would request Saupanika to also give the vote of thanks.
Any questions from the audience? Probably they are still digesting the words of Sir. I would like to thank our speaker for their wisdomful words. And then I thank our chairpersons for their insightful thoughts. And I would like to thank the IT team for their wonderful coordination. And also, I would like to thank all the listeners who are there till the end and making our webinar very much successful. Thank you all. Have a wonderful weekend.
Thank you very much.
Thank you, Saupanika, for doing a good job of the Master of Ceremonies.
Thank you.
Thank you.
Bye.